This is your recording on anti-gout drugs. I wanted to give just a very brief overview of what gout is, as many of you may not have heard of gout and may not be familiar with what it is. So gout occurs in three ways: either overproducing uric acid, under excretion of uric acid, or both, because those all lead to hyperuricemia. What happens with gout is uric crystals are going to accumulate in your joints. Most commonly, it's going to be your big toe. That then causes severe inflammation and very intense pain. Those uric crystals, those are going to develop from high levels of uric acid because your body produces uric acid when it breaks down purines. Purines are not only found in your body, but in a lot of foods that we eat, or even beverages we consume. Organ meats are very high in purines, as well as anchovies, sardines, mussels, scallops, trout, tuna, and alcoholic beverages, very commonly your beer, as well as your wine. So typically, uric acid will dissolve in your blood and it's going to go through your kidneys and into your urine. But if your body's producing too much uric acid or your kidneys cannot excrete enough, uric acid is going to build up and it's going to form these very sharp, they're needle-like crystals, and that's what goes into your joints, and that's where you get your pain, inflammation, and swelling. And you can see on the picture to your right, this is somebody that has an acute gout attack, how red, inflamed, edematous that foot is, very painful. And you can see the difference in the left foot. It's pretty substantial. And your gout attacks are going to be very acute and they're going to come on pretty suddenly. You'll take your medications, they'll disappear, and then they can come back without warning. To manage gout, we're going to do a combination. We're going to first try NSAIDs because those are our anti-inflammatory drugs. If those are not effective, then we will move to our anti-gout drugs. The overarching method of how those drugs are going to work is either blocking that formation of uric acid, helping to break down the uric acid, or increasing the excretion of uric acid in our urine. Our first drug profile for managing gout is allopurinol or Xyloprim. Allopurinol is going to work by preventing uric acid production by inhibiting xanthine oxidase. So we're going to use those in patients with hyperuricemia caused by gout, but it could also be from tumor lysis syndrome. The main adverse effects we watch for are skin-related. That's our exfoliative dermatitis, Stevens-Johnson syndrome, and toxic epidermal necrolysis. Contraindications are going to be hypersensitivity. Allopurinol is only administered PO. When you look at the onset, you'll see it's 1 to 2 weeks. How can the onset be longer than the peak? What do we think about that? So this means that it's going to take 1 to 2 weeks before we start to see effects of the medication. That's how long it's going to take for that to build up in the system. So it's very important we educate our patient. You may not see effects for 1 to 2 weeks. Then once we have enough of that concentration in the system, our peak will be 30 to 120 minutes with a half-life of 12 to 30 hours, and the duration is actually unknown. So the most important thing to note is that onset and educating our patients that it's not a quick fix. If we're having severe pain, then we're going to use our NSAIDs because they are anti-inflammatory until we start to see effects of allopurinol. Our next drug, febuxostat or Uloric. This drug is not used as common due to having a higher risk of cardiovascular events, but it is a lot more selective than allopurinol for being a non-purine selective inhibitor of xanthine oxidase. So same principles as allopurinol for managing gout. Unfortunately, because of the cardiovascular events, it may not be used as commonly. Our next drug, colchicine. This drug is used pretty commonly for managing gout and is the drug you'll see more commonly than allopurinol. It will typically be your second line agent with managing gout to NSAIDs. Funny story, actually, I took this same pharmacology class, although it's changed quite a bit, about 15 years ago. And I was working as a CNA. And I remembered this drug because it has such a unique name, colchicine. It was fun to say. It just stuck in my head. And was working night shift, and we got an admission. And when you get an admission from the hospital, you do a drug reconciliation. So the nurse was asking the patient about the medications she was taking. And the patient was having a really hard time recalling what meds she was taking. And the nurse said, okay, so you have gout. So are you taking any medications for that? And the patient said, I can't remember the name. And I had taken pharmacology. So I said, by any chance, is it called colchicine? And the patient said, yes, that's it. The nurse looked at me like I had two heads. She said, how did you know that? You were, as a CNA, how did you know that? Well, I just took pharmacology and I remember the name because it stood out, so it stuck in my brain. So hopefully this will be one of those drugs that sticks in your brain. So if you ever hear a patient saying, I don't know what meds I'm taking, but I have gout, maybe you'll think colchicine. So colchicine is going to decrease our inflammatory response to urate crystal deposits in our tissues or our joints. It's not exactly clear how the mechanism of action works, but it's thought through inhibition of metabolism, mobility, and chemotaxis of our polymorphonuclear leukocytes. Say that 10 times fast. So this drug is unique in that it can be used for prophylaxis, but it's more recommended for our acute attacks. So a patient could be taking this routinely if they get frequent attacks, but it's most commonly for our acute attacks. So we talked a while ago about renal dosing. So does anybody remember what renal dosing is? So if our patient has any sort of renal injury, we need to do a renal dose, meaning we're going to decrease the dose because if the patient cannot excrete this, it's going to build up in their system and cause toxicity. So if you see a lower than normal dose, it's likely due to renal dosing. In regard to adverse effects that we need to monitor for, leukopenia, which is a low white blood cell count. We can have bleeding in our GI tract. We can also have blood in our urine, which is called hematuria. And for our contraindications, of course, any hypersensitivity, and then any sort of renal, GI, hepatic, or cardiac disorders, and then our blood dyscrasias. If you look at what dyscrasia means, it refers to having a disease or a disorder. So blood dyscrasias is a general disease or disorder of the blood. This is taken PO. Our onset is 12 hours. Our peak is about half hour to 2 hours with a half-life of 27 to 34 hours and a 12-hour duration. Our last anti-gout drug is probenecid. Probenecid is categorized as a uricosuric. We use this for hyperuricemia for those with gout. How that's going to work is through inhibition of reabsorption of uric acid. What then happens is we have an increase in excretion of uric acid. I know there's a lot going on in this picture, but I think it's a pretty great depiction of what occurs. So you can see probenecid it's on the right and the left. But what happens is it's going to bind to our transporter proteins. That happens in our proximal convoluted tubule in our kidneys. You can see that in the middle. That's going to take our uric acid from our urine and put it back into the blood. That then becomes reabsorbed. So you're going to be looking at this from left to right. Contraindications for probenecid, peptic ulcer disease, renal impairment, and blood dyscrasias. It is PO with a 1 hour onset, 3 hour peak, a half-life of 3 to 17 hours, and an 8 hour duration.